Now, this is a very interesting CT scan of the brain, where you can simply pause and you can see and you can try to find out what is the problem. Now, what we can see, okay, this is CT scan of the brain. So we must know that whenever we are looking after CT scan of the brain, we know that the hyperdense or dense white structures on the CT scan is either blood or calcium or blood or bone. So we can see that here is all either calcium or bone or blood. This is not a place for calcium, this is not a place for bone as well. So this has to be a hypertensive bleed. This has to be hyperdense bleed. So this is bleed. So this is all blood. We can see that this is all blood which is present out here. Now we can simply trace the bleeding. So we can see this is an area of falx cerebri. That falx cerebri is the structure which separates the two cerebral hemispheres. So this is falx, and behind this falx, below this falx, is all blood. So this is in short a subdural bleed. You can see. This is all subdural bleed. This is also subdural bleed. This is subdural bleed. This is all subdural bleed because extradural bleed will simply have a convex margin like this. Extradural bleed will simply have a convex margin like this, but subdural bleed will have convex and concave margins. So in here we can see that this is the right-sided cerebral hemisphere, this is left-sided cerebral hemisphere, and you can see this is all hyperdense blood. This is hyperdense blood. So there is subdural bleeding along entire right cerebral uh, hemisphere as well as around the falx cerebri. Apart from that, we can very nicely see there is accumulation or accumulated blood. This is dense white, so this is blood. So there is presence of blood out here also. So we can have bleeding in the brain in three diseases or three conditions. One is hypertensive bleed. So we must know to remember the hypertensive bleed, we can remember PTPC mnemonic. That is, the most common site is putamen, which is followed by thalamus, which is followed by pons, and which is followed by cerebellum. So these are the most common sites of hypertensive bleeds, means the bleeding location in the patient who has persistent high blood pressure. In this case, the pons is spared, the basal ganglia is completely spared. You can watch my other videos to see this basal ganglia. The thalamus is completely spared. So, in short, this patient doesn't have PTPC or hypertensive area bleed. The second reason for bleeding in the brain can be aneurysmal bleed. If the patient has MCA, ACA, PCA territory aneurysm, then the rupture of this aneurysm can also cause bleeding in the brain. But we must know these blood vessels are all present in subarachnoid space. So whenever there is a rupture of this aneurysmal bleed, whenever there is a rupture of aneurysm, what you get is subarachnoid hemorrhage. But in this case, we are not able to see subarachnoid hemorrhage. This is all subdural bleed. So only one thing remains, which is potential cause of this type of bleeding, and that is drug induced bleeding. Drug induced bleeding means if some patient is on blood thinner, if some patient is on warfarin or rivaroxaban or apixaban or any other drug like Clexane or heparin, that can cause bleeding, and that type of bleeding can be like this. So this particular patient was on warfarin. We must know that the target for warfarin treatment, the INR is around 2 to 2.5 in most of the cases. Whenever the INR is more than 4, there is increased risk of bleeding, and whenever INR is usually more than 4, they can bleed in the brain. In this particular patient, it was 4.8. So this is a typical case of warf induced bleeding or drug induced bleeding, and this has a very typical these features. Few things which also I want to highlight in this case is this bleed actually, this images has two more things which we can see in here. If you can notice, the midline of the brain has to be around here. This is left brain, this is right brain, but in this case, because of this bleeding, this the midline is pushed toward the left. So this is the midline. You can trace this midline. This midline is pushed to the left side. So there is actually midline shift. You can see this is the left side brain and this is right side brain. So right side brain is much more than left. That is all because of the bleeding has simply pushed the brain towards the left side. So there is a midline shift. Whenever patient has midline shift, patient's GC will be much bad. There is increased risk of convulsion, there is poor GCS, and such patients may immediately need surgery. The last thing that I want to tell in this particular CT image is this. Now we can see that on the left side, we can very nicely make out this sulci. These are all sulci. These are all sulci. We can very easily make the sulci, presence of sulci. Here also, we can make the sulci which are very much prominent. But on the right side, you cannot make the sulci prominent. That is all because of the presence of cerebral edema. The edema is present because of the brain damage, because of the bleeding. So the bleeding is causing pressure, and this area of the brain is having cerebral edema. That is the reason why the sulci effacement is there. So this is a drug-induced bleeding, subdural hemorrhage extensively, especially on the right side, causing midline shift and cerebral edema as well. And that's all for today. Thank you.